probably want to ask you that question, because right now I can't even think about it explaining.
Mine has a
Yeah, why?
it's related to the mental.
Oh, we're sorry. Thank you. God, I wish I could say that was a test, and I'm sorry you have that. You know, we're going to burn these together. Of course, it's related to the polycythemia. Thank you, Megan. Megan had a little delay to explain herself, but not in her brain power. So hyperbilirubinemia is related to the polycythemia. Remember talking about jaundice? They already have all those other reasons that are normal, right? Now add on, they have extra red blood cells. So that's why. Respiratory distress syndrome is more likely in a baby born to a diabetic mother because the hyperglycemia interferes with development of some of the precursors to surfactant. So they're more likely to have immature lungs. So that's the reason. Which is so weird because before we had the 39-week initiative, the women that we always wanted to go early, and my daughter-in-law too, but thankfully it was okay, to deliver early because they were going to have a big baby or they're having some complication, were diabetic mothers. And their babies were more likely to have respiratory distress because they had less developed surfactant. Okay? So they're preemie already, maybe late preemie, but they're preemie, and then throw on that they have less surfactant. So these are reasons that we're concerned and the reasons that we screen for diabetes, because you can see. You don't have to memorize this, but this is a very recent article from JAMA. That says fetal exposure to maternal diabetes diagnosed prior to 26 weeks is associated with increased risk of autism spectrum disorder, according to a multi-ethnic retrospective cohort study. Big study, long study. This should be taken seriously because I haven't looked at the study in detail, but anytime you see something with 300,000, your N, let's say, your N is 300,000 and your time frame is this long, that's significant. I mean, that's a lot of people that they've looked at, so anyway. Okay, so here's our little care plan. This is posted, I believe, in your modules. All the, is that correct? Exam 3 care plans? Should have been. You shouldn't have to take a picture though, Angie. It should be posted in your Canvas. If it's not, I meant to. Can somebody look? Anybody on their computer? No?
Yeah, I can look.
No? Okay. Well, I think it's on there, and if not, I'm happy to because I usually do. So this is my little care plan of what we're going to do for assessment for a mom who's pre-existing diabetes or gestational diabetes. We're going to assess mom's knowledge. We're going, and of that, we need to assess all of this knowledge because she needs all this knowledge. So you have to assess it all because you may only need to teach her pieces and parts. If she's a gestational diabetic and has never been a diabetic, you're going to be teaching everything. And you're going to be teaching it probably to a stressed out, cranky mom who's real upset now because she does not get to eat for 2 anymore. Because she thought that she was going to get to eat for 2, yippee-yee-haw, and now we're like yanking everything back and making her count carbs, maybe even making her stick herself several times a day to get her blood sugar, maybe even making her take insulin. And for us, that's not a big deal, but for people who don't like needles, and there are a lot of them, and especially needles in their own self, this can be a really stressful time. So you want to assess, do they know the technique for what? For doing an AccuCheck. Do you all know the technique for an AccuCheck?
I do it twice in my shift.
You do? What's the first thing you do?
Turn the machine on.
Figure out whether they're
Well, I guess what I'm getting at is sometimes we think we do the technique properly and sometimes we don't. So when I say that, I mean we need to know where to poke on the finger or the heel.
And the sides,
Side of the finger.
Yeah.
and the sides.
And where should it be positioned, the thing you're sticking? Where should it be positioned in relationship to the body? Dependent is what I want you to say.
Okay.
I see a lot of people go in, hands are here, grab their hand, poke. Especially an old guy who's got calluses all over his hand, and you poke, and then you're like, it doesn't get it, and so now you have to dial that thing up to the biggest poke ever. Where if you just hang down and use gravity for a little bit, even now my fingers are getting full of blood, you know? Gravity, warmth, etc. That's it's a trick that I don't see a lot of people using, and I would encourage you to do that, because it really does allow you to use the smallest little poker on your little poker thing. You know how you dial how hard or how deep you want it to go? So we want to assess that, their ability to know diet. Now, your role as a nurse and how much of this you're going to educate will really depend on where you're employed and what level you are, and if you have a certified diabetic educator, or if you're in an office setting, you might just refer this person for diabetic teaching. Like, they have very good classes at pretty much all the hospitals, or I think Florida Hospital might give it at the endocrinologist's office next door instead of in the facility, but they have one. But Brandon Hospital has a very nice class for diabetics. So we need to teach them so that they know what carbs are. And how many carbs equals one serving? 15 grams. So that can be one cracker or one piece of cake or a fourth of an inch of cake, or it can be these awesome oatmeal cookies I got yesterday that were cheaters. And they only had like 4 grams of carb in them or something like that. So you need to know how many, because when you're prescribed to have 4 carb servings in a meal, you don't know what does that mean, right? And everything is different, so we can't memorize all that. You have to read your label. So we need to know, do they know any of that? What are the complications? I mean, some people think it's just being sugary sweet, it's no big deal. We don't want to scare them with all those maternal and fetal and newborn complications, but we do need to tell them that they do exist and that it's important for them to manage their condition. We need to know, and if not, teach them the signs and symptoms of hyper and hypoglycemia and fetal surveillance. Once we have a mom who is diabetic, fetal surveillance will be very increased, meaning by the time they get to 28 weeks, they'll probably be having an NST probably twice a week, probably a biophysical profile associated with one of those, so they'll have at least 2 office visits a week. It'll be covered by Medicaid or your commercial insurance or whatever. But what's not covered is getting time off from work. How about that? Yeah, twice a week. And you know, they don't always run on time. And that's reality. So that's another big deal. We tell this person, yeah, you're diabetic, you're going to do this, that. By the way, now you're going to start coming to see us twice a week. And in another 4 weeks, you're going to come 3 times a week. And they're like, and I'm trying to hold down a job so I can keep my insurance? You know, how is that? So these people have to file for FMLA usually, because if you don't, they'll get fired. Especially like if you work at the post office. I mean, like, you're either at work or you're not at work, and that's not good. So, you know, you can get fired for that pretty easily. So I'm just trying to tell you, there's a lot of stress with this. It sounds easy, it's not. When you say to your patient, now tomorrow, or I'm going to make an appointment for you to come in for a fasting blood sugar, and you'll need to be over at the Quest or in our office or wherever, at 7:30, 8:25, whatever it is, you might want to back up just a minute and have a dialogue and ask them, we need you to have your blood drawn at this time, at this location. Are you able to make that? Can you get there? Because if you just tuck, 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 and you never ask them anything, they'll take your paper and they'll smile and they'll say, thank you. And they're thinking, no way I'm getting out of there. Like, I don't have a car, the bus doesn't go there, and I've already got a ride from a friend today, I can't ask them 2 days in a row. You know what I'm saying? There are people who live like this. So, or their work, you can't get them to work. So we have to work with them. We have to talk to them and work on that. So the diagnosis is the risk for an actual ineffective health maintenance or risk for injury, perhaps related to hyperglycemia or hypoglycemia, etc. These are our interventions for the mom. Educate. What are we going to educate? All these things that we assess. Educate also on monitoring, insulin administration if necessary. Not all gestational diabetics take insulin. If they cannot be managed with diet and exercise, though, they probably will start them on metformin. If that does not keep their blood sugars under 100, or some of them even tighter, but at least under 100, then they'll probably add insulin. And that's slightly different depending on who's managing it. My daughter-in-law had an endocrinologist and a perinatalogist and a regular OB doing all that, which was kind of interesting watching them communicate, or sometimes not communicate. It's interesting. Recognize and how to correct their hypoglycemia. How do you correct hypoglycemia if you're the patient? What are our instructions to them? 15 grams grams of carbohydrate. Orange juice is good because it's very rapidly absorbed. But so is that little stuff they squeeze in their mouth you can get from the pharmacy. Okay? You don't want to give them something that's got a lot of fiber because that takes longer. So orange juice, or the real rule is 15 grams of carbohydrate, and then recheck your blood sugar again in 15 minutes, and if it's still low, do it again. You can do that cycle 3 times, and then you have to call 911. I don't know if it says this in your book, but common sense tells me that if you're a person having hypoglycemia enough to check and take 15 grams of carbohydrate, you should let somebody else know. What happens if it goes faster than 15 minutes and you checked it next and all of a sudden you're out, right? So I think probably not necessarily a 911 call, but at least a heads up to somebody in your house, your office, somewhere, your neighbor, somebody should know that you're in that position. And then what kind of support do they have? Neonatally, we're going to check their labs. Of course, we're going to do their glucose. We're going to do their H&H because they are at risk for polycythemia. And they're at risk for hyperbilirubinemia because of polycythemia. And so they may be a newborn that's more likely to get a serum bilirubin in addition to or instead of just the swipe it on the head transcutaneous one. Feed early. Now what are we going to feed our little babies born to diabetic moms?
Breastfeeding.
Breast milk. What if they're not breastfeeding? What if they're breastfeeding and they say no formula, just give them some D10? Can we give them D10? Can we give them some sugar water?
No, because
cannot.
it's gonna.
30 years ago, 20 years ago maybe even, you could. No more. Not in 2017. It has no nutritional value. It causes a huge rapid rise of glucose, which causes another huge secretion of insulin and then a huge crash. So they need formula. Now, that sounds easy. We're going to save this baby's life. We're going to give them some formula. Not always easy because the parents are like, no, evil, evil stuff. They can't have it. So what does that family need? Education and support. Absolutely. What?
She said counseling.
Oh, counseling. I didn't hear that. That's good, Sylvie. Okay, and again, the evaluation. So said my dear sweet Patrick. Sort of the same thing we did up here. Really, you're looking back to see what all their knowledge is. Do they still possess it all? Can they do their finger sticks, etc. Usually, the diabetic teaching classes, when they come there, they ask them to bring their glucometer if they're doing AccuCheck, so that they can make sure that they're doing it correctly as well. Okay. Questions? This is where we stick little babies to do their blood work. If it's not a venipuncture, they bleed pretty good, especially if you prep them well. The easiest way to remember, if I took this kid, my thumb was as big as this. If I put my hand here and my thumb would be over this spot in the middle, you see, kind of wrap your thumb on the foot like that, and then your hand's right down the middle, and I assure you, you won't poke in the wrong place because that's where your thumb is. So just a little hint. Sometimes they have to dorsiflex the foot really far. And even with metabolic screening, sometimes it requires a pretty good dorsiflexion of the foot, and so they don't usually let you guys do that because you don't do it enough. You go like, but really you have to really fold it back sometimes to get it if it's not prepared. Questions on diabetes, what it does to mom, fetus, newborn? Why do we care? What are we going to do? Questions? Good. Okay. Disorders in pregnancy that are related to cardiac. We know that normally there's an increase of vascular fluid for the mom, 45–50%, depending on which textbook you're looking at. But they also, because of that, then have increased heart rate, increased stroke volume. In addition to that, pregnant women have increased fibrinogen and other blood clotting factors, so their blood's a little bit thicker, which predisposes them to what? Clots and strokes, heart attacks. So you can say cardiovascular accidents, as well as SVTs and DVTs. So that's normal. All right, here are classifications of heart disease. In a perfect world, class 3 and 4 would never show up on our radar in being pregnant because they're significantly impaired already, and the stresses of pregnancy will be very dangerous for them in the fetus. But we know that 50% of women don't plan on getting pregnant, do. So that's going to happen, and we're going to see these women. So that's not good. But class 4 means they just sit in their recliner with their O2 on, and they're already short of breath, tachycardic, etc. So that's not a good position to be in. 1 usually has none, and 2 might be that person who has small mitral valve prolapse or a little prolapse in the mitral valve and didn't even know it until all this extra fluid came, and now they're symptomatic from it. Those symptoms are usually with mitral valve prolapse. What are those, do you know? A major one. Palpitations. Right? Doing the heart fluttering, beating, etc. Now these are signs and symptoms of cardiac decompensation. It means your body, whether you're pregnant or not, is not compensating for whatever it needs to compensate for. So if it's a low oxygen or extra fluid that it has to pump, whatever it is, your body is no longer making do. It's not working. So we can also call it congestive heart failure. Sometimes it's called left-sided heart failure. But these are symptoms of it's not going well. So they have a cough. What kind of cough do we have? Usually a wet cough, absolutely. Progressive dyspnea with exertion. Orthopnea, which means what? Yes, difficulty breathing laying down. So these patients, you'll see them sit up. They may sit up high, Fowlers in the bed, sit on the edge of the bed over their pillows, or over their over the bed table or something like that. I've had patients back in the day who used to bring in their own recliners into their hospital rooms, and they would sit there. That was before we had nice furniture. Now we have nicer furniture in the hospital. Edema, and I'm not really talking about at the end of your 12-hour shift edema, like Morgan is probably having, right? Morgan. Yeah, because she's like 20-something weeks now. So she's probably getting dependent edema at the end of her 12-hour shift. So that's the kind of edema. Edema of the hands and face, not the ones just of your feet. Okay, because that'll go away by morning. But swelling of the hands and face, again, a warning sign. Heart palpitations, and will your patients say, oh, Sasha, I'm so glad I got here. My heart's been palpitating like crazy. Probably not. What might they say?
Feel a flutter in my chest.
Feel a flutter, my heart's galloping, I can feel it, it's like gonna come out of my chest.
I feel there's a bird in my chest.
Yeah, a little bird fluttering around in there. Tachycardia, which is a heart rate over 100. Progressive fatigue or syncope with exertion, and moist crackles in the lower lobes. Those are all signs that we are not compensating for this cardiac condition, whatever it is, whether you're pregnant or not. Rheumatic heart disease, pretty much everything I really want you to know is right here. It's caused by an undiagnosed, untreated group A beta hemolytic strep, which is very uncommon today because we have rapid strep tests and antibiotics, if you're not allergic to penicillin, that are so cheap you can get them free at Publix. They're cheaper than your copay because they're free. And other places do them free as well, but because penicillin is usually the drug of choice, PenDK, which is very, very inexpensive. The problem is that once, if you do not have a diagnosis of your strep and you do not treat it, that bacterial infection in your throat, it's called self-limiting, meaning it will go away all on its own. That does not mean that the bacteria has just vanished, evaporated from your body. The bacteria can travel to 2 different places in your body and wreak havoc and cause irreparable damage that you'll suffer with for the rest of your life. One of them is on the valves of the heart. And it will cause then the valve does not open and close correctly. So it's leaking blood around that valve, whichever valve has been affected. So what's the other place it goes to?
Does it cause meningitis?
Kidney. Causes glomerulonephritis, and it causes permanent damage to the glomeruli. And they never come back from that. So depending on how severe it was, et cetera, and how long before you got treated, will depend on how big a deal it is. But you don't see this too much anymore because of the advances that we have. Question? talked about congenital heart problems and shunting before, haven't we? We did in peds or?
A little bit.
Okay. So shunting, I know we did for Cornelius and I did, because he had a baby in the NICU who had it. So the shunting, and we're just going to skip it. I don't care. Mark it off.
All of this is not going.
Well, I mean, yeah, I'm not going to ask. Okay, therapeutic management during the antepartum period for class 1 and 2. Again, class 3 and 4, they really shouldn't be great. But limit their physical activity. I don't think there's a whole much extra other than saying this. Avoid excessive weight gain. Prevent anemia. And how can we prevent anemia? How can we help our patient prevent that? Taking their iron supplement. In fact, these patients may take a prenatal vitamin plus a ferrous gluconate or sulfate or something like that in addition to just the prenatal vitamin. Prevent infections. Monitor the condition for signs and symptoms of cardiac decompensation. And what are those?
The ones that we can talk about.
That's right. They're those. That's right. Now, continuing on with the antepartum, in class 3 or 4, we're going to do all of those things on the last page, plus maybe they're going to be on bed rest. And plus, when you get to NP4, you're going to really dive into all these medications. Well, anti-infectives you know about, but the heart medications, etc., you're going to get into those. For now, I want you to know these 4 categories. So for the patient who is pregnant and has class 3 and 4, heart disease, they're going to do all the things we just said on the last page, plus maybe bed rest, and maybe these medications. Anticoagulants, because they're on bed rest. Anti-dysrhythmics, because they may be having dysrhythmias. Anti-infectives, and heart failure meds. There's a bunch of those, and you'll be talking about them next semester. Okay? So that's antepartum. Intrapartum, a couple of things are different here than for the regular patient during intrapartum, in that they're pretty much all going to have an epidural, which is going to get them all a continuous electronic fetal monitoring, and we want to assist with their delivery. I put forceps, but we know in real life that's probably not what's going to happen. It'll probably be a vacuum, but it's technically correct. So we want to assist their delivery. Why?
Stress on the heart.
So they don't go vasovagling on us. So they don't go, which is the way most people push. So we don't want that to happen because that can cause syncope, etc. Okay. And most of our patients do not have oxygen or pulse ox. Most of them don't, do they? Most of our laboring patients? Unless there's something wrong with them. And there could be something wrong with this one. So that's the only difference. Okay, nothing other than those words you need to know.